Dr. Farid? Good afternoon, Dr. Anaba. Thank you for joining us. Hello, Dr. Jonas. Good afternoon. Thank you for joining us.
Yes, hello, good afternoon. I hope you can.
Yes, please. Yes, we can hear you.
But Zoom is unable to detect my camera.
Okay.
Just give me a minute to let me sort out my camera. Otherwise, at least you can hear me.
Yes, sir. All right. So to our audience members, thank you so much for joining us. Hello, Prof. Welcome. Thank you so much for joining us. Okay. So we would like to give our audience members maybe 5 minutes to log in before we officially start our program. Dr. Babin, thank you so much for joining us. Welcome. We just want to give our audience members 1 more minute to join us and we'll officially start the program. Hello, everybody. Hi, good afternoon, all of you. Thank you so much for taking time out to sit here. Hello.
Hello.
Hello, Prof. Good afternoon. All right, so it's 4 minutes past 4. Yes. So we'd like to officially start our program. My name is Dr. Amadu Munira. I'm a first-year surgical resident at the Tamale Teaching Hospital, and I'm the education chair for InciSioN Ghana. So some of you have been with us before, others are joining in for the first time. But InciSioN Ghana is a group which is a subgroup of InciSioN Global. It's basically an association made up of medical students, junior doctors, and other specialists that have come together all in the aim of pushing the global surgery agenda. What we want to do is that we want to do the little we can in order to help people realize the gap in surgical needs of people in low and middle income countries, and then the expertise that they have and the access that they have. And what we in the InciSioN group Ghana, the education subgroup, what we are trying to do is we want to act as a bridge between undecided doctors and medical students, those who are yet to decide on their specialty, give them access to specialists, consultants, professors in their field, people who have excelled in their field, give them the chance to communicate, and hopefully try and encourage people to consider surgical specialties and other associated specialties such as anesthesia, which is our main focus for today. So to start with, we all have 4 exceptionally talented, educated individuals that have excelled in the field of anesthesia, who are all coming in today to try and talk to us about anesthesia, answer our questions. We are all trying to learn as much as we can about anesthesia. So to start with, one of our panelists here is Professor Gladys Amponsa. Professor Gladys is a graduate of the University of Ghana Medical School. She went to the University of Liverpool, England for her postgraduate studies in anesthesia. And she came back to Ghana to join the University of Ghana Medical School, Department of Anesthesia for 30 years. She then left to help expand the newly established medical school at the University of Cape Coast in 2009. And she then came back to Accra in 2015 to continue her career. Over the last 4 decades, she has been instrumental in teaching undergraduate students, teaching and training of postgraduate doctors and medical officers in the field of anesthesia and in research. She has a number of peer-reviewed scientific articles to her name, and she has received several awards and citations, including a meritorious award from the Ghana College of Physicians and Surgeons and the Institute of Directors, Ghana. She is also a fellow of the Ghana Academy of Arts and Sciences. Professor Gladys Amponsa, please, if you could turn on your camera, let your audience meet you. Hello, Prof. Our second able-bodied panelist is Dr. Thomas Anaba. So Dr. Thomas was born in Garu in the Upper East region of Ghana. He's married and blessed with 2 beautiful children. He had his education in Ghana and also outside of Ghana, and he currently holds a master's in critical care, emergency, specialist anesthesiology and resuscitation, and a number of health management certificates. He is a senior lecturer at the University for Development Studies. He was a senior lecturer at the University of Development Studies in 2012, and he helped develop and introduce the first ever nurse anesthesia basic science program in Africa. He became the HOD of the anesthesia department and also established a private hospital, which most of us in Tamale know as Habana Medical Service. He is also the current CEO of a health policy think tank called Africa Center for Health Policy Research and Analysis. He's a fellow of the Ghana College of Surgeons and Physicians and an academic board member for the Faculty of Anesthesia. He's a fellow of the Cuban College of Anesthesiology and Resuscitation, a member of the Ghana Anaesthesiologists Society, and an associate member of the Association of Anaesthesiologists of Great Britain and Ireland. He has contributed to several policies, such as the Policy and Guidelines for Hospital Accidents and Emergency Services in Ghana, including guidelines for public health units in hospitals for the Ministry of Health. Dr. Anaba, if you could also just say hi to our audience, please. Boss, please, your mic is off. Okay, hello. Then next is Dr. Jonas Afari. Dr. Jonas is a specialist anesthesiologist with 12 years experience and a total of 18 years working experience in anesthesia and critical care, currently working at the Kulibu Teaching Hospital. He has a diploma in anesthesia from the West African College of Surgeons, along with a membership also from the same college. He is a member of the Ghana College of Physicians and Surgeons, and he has an associate membership from the Royal College of Anaesthesiologists, UK. He has a certificate in health administration management from the Ghana Institute of Management and Public Administration, and he is also certified by the American Heart Association as a trainer in basic life support, pediatric advanced life support, and is an instructor in emergency care for the National Ambulance Service paramedics. He is the anesthesia country team lead for Operation Smile in Ghana, and he is also influential in delivering critical care services to those in Tamale, Cape Coast, Ho, and Koforidua with the Operation Smile team. Dr. Afari, if you could also say hi to the audience.
Let me say good afternoon to Prof, to Dr. Thomas, and to all our audience. Thank you for making the time this otherwise busy weekend.
Thank you.
And our fourth panelist is Dr. Obapenyin Akwanyako. She is a resident at the Kwampanoti Teaching Hospital and has been in the department for the last 4 years. While working there as a house officer, she fell in love with the organization and skill that goes into delivering safe anesthesia. She is currently the treasurer for the GMA Ashanti Division, and she is a strong advocate for preventive health and speaks regularly about ways to achieve good health. Dr. Obapenyin, if you could also say hi to the audience.
Hi.
Hello. So, to our four panelists, to start off with our program, we would like to hear from you. If in 1 minute, starting with Professor Amponsa, you could tell us what made you decide on anesthesia as your career and how you got to where you are now. Professor Gladys, please. Professor, please. Yes. Hello. Hello, Professor, please, can you hear us?
Yeah. Okay.
Yes.
I said. Clinical pharmacology with a view of going into industry to follow my teacher, okay, or anesthesia. God chose anesthesia for me because I was put into the department without even my knowledge as a medical officer. End of story. And I've never turned back. So all my life, I've done nothing else as a medical person except anesthesia.
Oh, wonderful. Oh, wonderful. All right, then to Dr. Adaba, if you could also tell us in 1 minute, what made you decide on anesthesia as your career path and how you got to where you are now?
Thank you very much. Greetings to all the audience. I joined anesthesia simply because when I was a medical student in Cuba, I had the opportunity to rotate in several departments. And anesthesia appeared to me to be the specialty. That when you pursue anesthesia, any other specialties grow in the career. the rest. So I just saw it to be an all-in-one.
What made you decide?
All right, so trying to keep it down to 1 minute. As a medical student, I was trying to keep all my options open. Final year, thinking about everything I would do. By the time I did my anesthesia rotation in medical school, I liked it. I must admit, part of it was the faculty, and that goes on beyond. Generally, you'd realize that most anesthetists, I think, are pleasant people. It comes with the job. So I enjoyed the faculty. Even before then, I did an elective medical rotation outside. I was in the United States. It was a private facility, and I enjoyed the whole atmosphere, the ambience, the skills that they had. Came to Ghana, did it in final year, realized it was the same. Thinking back, looked at it, I had patient contact, which I wanted. At the same time, I didn't want the patient contact to be stuck with me, as in if I was into internal medicine and you're going to have a patient for 20, 30 years. I have the patient contact, not stuck with me unless it's a critical care case. And even then, once I deliver and I get you out of the critical issue and I discharge you, it's no longer a burden. I could see both sexes, males and females. I could see all ages, from premature to even geriatrics who were coming. I was involved in a lot of critical skills in resuscitation, in airway control, in fluid therapy. So it was a combination of all these things, and realizing that I enjoyed what I did. I could keep abreast with all the fields. Today, I'm talking with a pediatrician. Tomorrow, I'm talking with a nephrologist. The next day, I'm working with a surgeon. The next day, it's a medical case that is being directed. So it sort of kept me on my toes as far as all aspects of medicine were concerned, and I enjoyed it. Thank you.
Thank you so much, Dr. Afari. To Dr. Obapenyin, if you could also tell us in 1 minute why you decided on anesthesia.
Okay, so anesthesia was not my first option, actually. My first option was obstetrics and gynecology. And I'm someone who likes to work with my hands. So internal medicine was not going to cut it for me. And I thought more of a surgery specialty. But then in my final house job rotation, I had the opportunity to go and be in the pediatric intensive care unit. And I got in contact with the machines and things they use in the intensive care. And I decided, okay, let me give anesthesia a go as my last rotation for house job. And I did it and I fell in love with it. And so when I was down my house job, I had the opportunity to come back to Confanoche, and I decided to do anesthesia. Yeah, so for me, that has been why I chose anesthesia.
Okay, wonderful. Thank you so much for sharing that with us. We would now like to go on to our main part of our program. So first off, I'd like to start with Dr. Afari. My question for you. Most of our people here are medical students or house officers that are yet to decide on what they want to do. Were any one of them to decide on anesthesia, what is the training pathway in Ghana like? What are the entry requirements, or what are the eligibility requirements for anesthesia?
Okay, thank you for this question. Training pathway is straightforward. Finish with medical school, pass out, graduates. As far as the government of Ghana, Ministry of Health, Ministry of Education are concerned, afterwards you are going to complete your house job. Currently going to be a two-year duration of 4 rotations. You finish with that. Along the line, fortunately, giving you more exposure, one of your 4 rotations can be, if you're in the teaching hospital, can be with the Department of Anesthesia. I think that's a good way of giving you some more exposure, some working experience within the field, and then realizing whether the interest that you are gaining there is going to be sustained or not. To enter the training programs, for the membership program, you have to write the primary exams. So within the period of after house job, during house job, you can start preparing towards the primary exams. You don't have to be in the training institution to write the primaries. Or after house job, if you are working as a medical officer elsewhere, you can write the primaries. It's of great advantage if in your quest to do anesthesia, you let us know, let other anesthesiologists know, let your head of department or head of whichever institution you are in know. That could help get you posted to one of the training institutions where just being with your fellow colleagues who are all pursuing anesthesia or all preparing for the primaries would help give you an edge. But then after the primaries, you formally enter the program. That's the Ghana College program or the West African College program. The membership duration is a minimum of 3 years, doing all the required rotations. So let's take that 3 years. After the 3 years, passing the membership successfully, you can apply for the fellowship program. The fellowship program is also a minimum of 2 years. In practice, being very fair to you, not hiding anything, it may take a bit more than 2 years because of some of the rotations you'll have to do and then ethical clearance and preparation towards your dissertation. Right now with the fellowship, there's a lot of sub-specialization. So if you are doing a sub-specialization in, let's say, pain fellowship, you may have to do some rotations with neurology and radiology and the like, not more than 2 to 3 months at the start. But then that's all what may make the fellowship a bit more than the 2 years. So in short, membership 3 years, fellowship an additional 2 to 3 years. For the diploma program, you do not need to write any primary or entry examination. Once you are in the institutions that are offering the diploma program, that is with that's the West African diploma, you just have to be working within the field for a period of 18 months. And then within that period, you write the examination. And it is very practical. Once you are working, you have colleagues who are teaching you along the way. It is very simple to get the diploma, which makes you qualified to safely deliver anesthesia. Most of us do the diploma side by side with our membership so that you end up with, let's say, dual qualification. Recently, the Ghana College of Physicians and Surgeons has also introduced a modular diploma program. So this is its first year of inception. The first batch have just actually finished their first 2 modules. That is a situation, that's a training in which you can do it more or less from a distance. So instead of taking a long period of study leave, having maybe hindrance for whichever hospital you are with, you learn where you are. You come at specified periods for lectures. There are very regular tutorials. You come for clinical attachments at designated nearby hospitals, and you also end up graduating with the diploma. So in short, the training, the diploma, no entrance exam, membership entrance exam, 3 years, fellowship, finish the membership, and an additional 2, maximum 3 years, and coming out with a sub-specialization of your choice. Thank you.
Great. Thank you so much for that information. My next question is to Dr. Obapenyi. Doc, please, we wanted to know, in your current residency training, how do you find the training program of Ghana College versus West African College? Which one is more competitive?
Sorry, what do you mean by competitive? Let me
as in the training path you are on. When you compare the training of Ghana College versus the training of West African College, how do you find the training to be like? How do you find the opportunities available to an individual were they to pick one college to go with after their program? What are they looking at?
All right. So I personally, I just did the Ghana College. I have not done the West African College, but I'm doing the diploma concurrently with my residency. But looking at my fellow colleagues who are also doing the West African College, I think the West African College, the curriculum is more encompassing. They get to do rotations in the districts, which the Ghana College does not do. And I think it gives you an opportunity to practice outside your normal scope, which as an anesthesiologist, you do need to be able, you should be able to provide service, even though the best way is to be at a place where you know where all your drugs are, where all your resuscitation equipment are and everything. There are some opportunities where maybe you may be called to an out of comfort zone location, and you should be able to handle and establish leadership. As an anesthesiologist, you are the lead for resuscitation, and you should be able to do that. If you are always in a place where you are comfortable with the people around you, you may not have that experience of taking lead, because then automatically they know that, oh, the anesthesiologist around, give the person the room to. But when you're somewhere else, I think it kind of like broadens your scope, for lack of a better word. So I think for West African colleges, it's more, for me personally, that's what I think, that is more encompassing, like you get to do all those rotations as compared to the Ghana College. I hope I've answered your question.
Yeah, thank you so much. Going back to Dr. Anaba, what we would like to know is, in your extensive career and in your time as a specialist, what we want to know is, what aspects of your career have you found to be extremely rewarding, have you enjoyed, and what aspects have you found to be very challenging?
Thank you very much. I think very rewarding is when I'm able to discuss any topic, any case with any specialty. Talk about a neurosurgeon, they come in to discuss a surgery, you are able to participate and you feel that yes, they feel that yes, you are a part with them. Pediatrician, one, you want to do a surgery with the pediatric surgeon or pediatrician, and you are able to communicate and people seek your opinion, and they say, what, you did a good contribution, and then the rest. Yeah, she was just talking about how she went at NICU. NICU, you know, mostly is handled the ventilation, the rest is handled by anesthesiologists. You see that you are in the NICU working with NICU. When it comes to labor analgesia, women who don't want to have pain during delivery, give them some good labor analgesia using the epidural catheter. And they come out and they see you anywhere, they say, oh, this is the man who gave me analgesia, I didn't have pain when I was delivering. And so on and so forth. There are so many good things about anesthesia, especially when you are going to theater, you will take this patient and educate him about the anesthesia, what it entails, and what benefits they are making from the anesthesia. You lay away his fears about the anesthesia, you bring him out very smoothly and he's comfortable. They tell you, doctor, thank you, I never experienced anything. You really did what you told me you were going to do. It is very life-saving, and it is very pleasant to listen to those things. Again, you go to the emergency department, where the emergency physicians sometimes are struggling to handle the case. They call anesthesiologists to come and take over. You are able to work through. At the end, you are going, and everybody say, wow, this is a great person, this is a great man, this is a great doctor. You feel very comforting and the rest. So those are some of the good things about anesthesia. What the bit of it that I don't like so much is when patients who don't really meet you very well before they go for surgery, they finish, they see the surgeon and give him thanks and leave you alone, and they look at you as if you are just a passerby. Meanwhile, you are the real person who handled his life throughout surgery. And as Dr. Afari said, we just meet patients. Once we treat them, they get well, and we part ways with them. We don't keep them for long. So they may not be recording your face to give you thanks on the street and other things. Those things are really not rewarding. But in general, anesthesia is a very rewarding specialty because you cut across, you meet several specialties. You can discuss any topic in anesthesia because we are much abreast with physiology, pharmacology, anatomy, and we keep lives running when everybody is running away. You can see coronavirus, where it came. You see how all the anesthesiologists were rewarded by, praised by the Ghanaians because they handled the very critical cases. When everybody was going away, we were the ones in the ICUs taking care of them and the rest. So this is a rewarding specialty that you would encounter so many doctors and then you help them take decisions that are very fruitful for the patient.
If you don't buy it, you don't do it.
Wonderful. So the next question, this one is for both Dr. Afari and Professor Gladys. So, Prof, what's the question we want to know is, according to the WFSA, they recommend that there should be at least 5 anesthesia specialists per population of 100,000 in low to middle income countries. Looking at the time you have spent in anesthesia, in the career, looking at the evolution of anesthesia as it was several decades ago and how it is now, what do you think it would take for this to be a reality, for 5 anesthesia specialists per 100,000 population in our country?
Thank you very much. The problem is not even the ratio. The problem we have in Ghana, for example, is the distribution. Because Kolebu has so many specialists, followed by Konfanochi and 37 and so on and so forth. But they are all in Kolebu. That's what the problem has been in our part of the world, is the maldistribution of the few specialists that we have. And so until we are able to solve that, we can never get that issue that WH is talking about. That's my big problem. People have to be prepared to move out into the other areas. Otherwise, we will never get that issue. The second point is that we said over the years that people should be encouraged to go into incentives. You know? Yes.
Oh, it's like you're breaking up.
I'm breaking up. I said, you said that people who want to do anesthesia, or for that matter, people who have done research want to go outside the cities should be compensated. I think we are not there yet. They should be compensated for doing that, because we know the importance of anesthesia in every aspect of medical care. From the trauma patient to the obstetric patient to the medical patient. I mean, we have managed Guillain-Barré syndrome in Kolebu before successfully. Everywhere, as my young colleagues have said, every branch of medicine, anesthesia has an input. So the governments of our sub-region or the government of lower and middle income must have special packages as incentive. That is one of my main contributions, incentive for them. Thank you.
Thank you very much, Prof. To Dr. Afari, what are your thoughts on this issue?
Yes, you might have realized I've been smiling throughout Professor Amponse's submission. I wanted her to take the lead because she is more experienced, but at the same time, I feared that she would take the very words out of my mouth. And that makes it the truth. That makes it the facts on the ground. Those are the very words I've written here. Number one, distribution. She's mentioned that by the grace of God, our numbers are slowly but certainly increasing. But it's taken time for us to expand beyond the urban areas into the rural areas. Partly because of that, we don't have the recognition. Dr. Naba mentioned that even the patients that we deal with, a lot of them don't recognize us as a specialty in medicine. But fortunately, now we have Professor Mrs. Amponsa. We have had professors, Professor Drew, Prof. Yawudi Jemfi, so we can get to the very top of our fields, but the layman sometimes thinks of us or doesn't recognize us or thinks we are technicians. So then that recognition will come. That will also encourage more young people to get into the field. Incentives are very essential. That also comes with the recognition. The government, all the policymakers have to realize the important role we play and the fact that our numbers are critically low. There is nothing wrong with realizing that need and building up where necessary. I'm not saying any other specialty is not important, but then when you realize that this ratio is so low, in the past, there used to be some incentives like as far as housing in Kolebu was concerned. Once you're within the department, you are given some preferential treatment just to encourage the numbers. There used to be some incremental jumps with your additional qualifications. All those are important things that would help grow our numbers, incentives for others to come in. Fortunately or unfortunately for us, our training here is so good that it is recognized by some other institutions like the Royal College of Anaesthetists. So this is a situation whereby with our training, if we are not given the due recognition and incentives to stay within our country, a lot of our members can get up to the middle level of training and go and get much greener pastures elsewhere. What I'd like to add to Professor Ampo's submission is that also to help with the distribution, to encourage anesthetists to go outside the urban areas. Yes, the government is building up the surgical specialties. I cannot learn so much within 3 years and then end up going to a facility that, because of lack of surgical specialties or because of lack of equipment, the scope of my practice is reduced. It will not be challenging enough for me to just be doing simple cases day in and day out. So with our recognition, with our incentives, if there's a push to make sure that we have the right equipment, we have the right surgical specialties to work with, we have intensive cares and the like being set up, that would be more challenging for us. And that, I think, would encourage us to move out of the urban area, go into other places, and know that we are not losing any skills that we've learned for lack of practice. Thank you.
Hello everyone. My name is Theophilus. I'm chair of InciSioN Ghana, and I think Dr. Munira's internet is also. I'll just take over until she joins us. Thank you very much, Dr. Fari and Prof, for answering this question. I think that we had a similar question we wanted to pose to Dr. Anaba as well. As far as we are aware, it appears Dr. Anaba may be one of a couple or a few doctor anesthetists in the perhaps top half of Ghana. Dr. Anaba, would you mind telling us what are some of the reasons why you chose to go to the north?
Thank you very much. I think I chose to come to the north because and I also surveyed the place and realized that there was no single specialist in the whole of the north. They wanted to set up the medical school base of the medical school. No anesthesiologists for them to get the accreditation. So I was approached that time. I'm not being tribalistic, but I'm also a northerner myself. So I just thought it wise that let me come home to help my people. That is what motivated me. I came and luckily I didn't have those challenges that Dr. Afari is mentioning. Luckily, the Spanish embassy came. They asked me of what I needed to set up the department and also run an ICU. I gave them a list, and in less than 3 months, I got all the equipment needed to set up an ICU at the time at the teaching hospital, which was one of the things I needed to have so that I could practice good anesthesia and critical care. Luckily, when I was coming to one other doctor who was a specialist as a neurosurgeon at Rich Hospital, so also decided to come. So I knew that there would be complex surgeries for me to perform. Keep my skills. So all this motivated me to come. Also, I thought that when I come, I would be able to groom and support the nurse anesthetists who were here so that they practice good anesthesia, which I got the opportunity to do and even set up the BSc nurse anesthesia program, which they are currently running at the UDS. So it was because of necessity of specialists that I decided to come, and I also saw an avenue to open up on my own and also develop my skills and manage things, and that is what motivated me. Still here in Tamale.
Excellent. Thank you, Dr. Naba. And as you've already raised this, I'll just ask Prof about this. I'll come back to you, Dr. Naba, on this question. Prof, as it stands now, it appears tax sharing is the major play in Ghana, given that most district and regional hospitals have anesthesia services being delivered by nurse anesthetists? In 1 minute, what is your opinion on that?
Thank you. If I let me just continue where Dr. Anaba left. Training should be decentralized. That's one of a very important point I missed. Because you see, before UDS came into the country, we have problem also of not anesthetists, but even medical officers. But we know that when UDS was established, and doctors who were trained, even those who came to Kolebu to be trained, I know some of them, they went back. Why am I saying that? Because the cultural milieu in which you work is also important. We can't escape that one. So that's what I would say. We need, as I was sitting, because all the questions was about training institutions. We haven't done that one. So let me just chip it in. Currently, we have Kolebu, Konfanochi, 37. To my mind, we should have one in Tamale, we should have one in Cape Coast, we should have one in Efiem Kwanta, and we should have one in Hope. If we begin training anesthetists in these other locations, it's a matter of time. The spread, I mean, if you have done 4 years, 6 years in Hope, moving your bag and baggage back to Accra may be difficult. You may be more enthused to stay in Hope. So this is something which we are working on. We've been trying hard, but you know, the power does not lie with us. We can only talk to the right people. And we hope one day this thing will be achieved. So that even during training, we have people who can even advise the nurses who are around. Finally, there's also a program in place where the country is going to be zoned. And every zone will have a physician anesthetist supervising, whether remotely or wherever. Now with IT, it doesn't matter. People are supervising people from Canada to do surgery in South America. Look at the distance. So we are waiting for that. We are waiting for government to start the zoning and demarcating the country into proper zones, allocating anesthetists and anesthesiologists for these zones, so that we can have, even from the beginning, a doctor looking in or looking with one eye into every district in this country. And that will be a good beginning before we get the training institutions expanded and more doctors being trained in their locality.
Thank you very much, Prof. I just wanted to ask Dr. Ekwanyako, just on the same issue on nurse anesthetists. I mean, there have been several reports and about defining roles between what a physician does and what a nurse anesthetist does. Are there any limits? I know you are a resident, but from your experience, are there any limits to what you think a nurse anesthetist should do and what a doctor should do? And if you were to work later on in a department where you are, what would you think would be your sort of role as opposed to that of a nurse anesthetist?
Okay, I think, yes, it's very important that roles are defined, because then and boundaries are defined. In any society that there are no clear-cut boundaries, we tend to have people doing things they are not supposed to do with no oversight, no responsibility. So yes, their roles need to be clearly defined, which I think listening to everything that's going on around with the issues that we're having, I think that's the main thing, that the roles were not defined. Up till I think about 2 years ago, in my institution, there were only, I think, just about 10 specialists, anesthesiologists, and Konfanoche. It's now that we are trying to get more people on board to specialize. And as such, there was the over-reliance on nurse anesthetists. I think there are certain complex issues, complex cases that nurse anesthetists should not be allowed to handle. And they should, I believe they should also work under supervision. I'm not for an open for all society. There should be established rules. There should be, like, in the same way where if I come to the hospital, I have my specialist that I report to that supervises me. In the same vein, a nurse anesthetist should report to a doctor and should not be allowed to practice on their own. I hope I answered the question.
Yes, you did. For the next 1 minute, Dr. Naba, what are your views on that?
Thank you very much. This has been a very in the country. Nurse anesthetists are really trained to handle very basic anesthesia, simple surgical procedures, and life-saving procedures like cesarean sections, where you don't have complex surgeries to perform, complex monitoring to perform that surgery. That is what they were trained for the rural communities. But it turns out that some of our regional hospitals do not have specialist anesthesiologists. Like in Tamale Teaching Hospital, we didn't have a specialist anesthesiologist until I came. So it was up to them to be able to provide anesthesia for such specialties. However, the guidelines stipulates that anesthetist should be under the supervision of the surgeon or any anesthesiologist who is there. But they have decided to create a movement association due to their numbers to be challenging. I think that the onus lies on Medical and Dental Council to come out with guidelines with the Society of Anesthesia, guidelines and job description, so that if you make a mistake and jump into any case that you are not supposed to and it complicates, you should be held responsible, so that the lines will be drawn. In fact, let's not deny it, the nurse anesthetists have done so greatly in this country because of their numbers. But for them, a lot of maternal mortality would have occurred. But I still insist that there must be guidelines of how they should operate in any hospital they are.
Thank you very much. Dr. Fari,
Mr. Moderator, yes, if I could just come in briefly.
Yes, I was going to ask you, as the Secretary of the Association, what are your thoughts?
So,
yes, please, Prof. Prof, I think you're breaking up. But I was going to ask Dr. Fari to tell us what the association's view is on this matter and what is being done to handle it.
Good. Thank you very much. So the association, we are the Ghana Anaesthetists Society. We represent the physician anesthetists. Let me state first and foremost that it's unfortunate that it's like issues of disagreement or misunderstanding. They appear to get the most limelight and publicity. Yes, there have been some differences. There have been some wrong utterances made. But a lot of times, what is supposed to actually happen does happen. It's the sort of situation where a few bad nuts can appear to spoil the entire field. The importance is that in our work with our certified, registered anesthetists, I am being very careful, very political, using the term that has been assigned to those who were previously known as nurse anesthetists. We play very complementary roles. It is teamwork. I think what is important is that the supervision has to be recognized that it is coming from the physician anesthetists. It's not just our level of training, but then when it comes to the situations of working with our surgical colleagues or other colleagues, partly because of our level of training, it tends to give us some more degree of confidence to communicate further with them and to prevent instances of bullying. The physician anesthetist is better able to discuss the case and point out and stand his ground where situations are not in the optimum interest of the patient. I think there should be, and there is to a great extent, mutual respect amongst us. But then the supervisory role of the physician anesthetist is needed, because even when simple cases are done and complications arise, then you are moving more into the domain of critical care. And we are better suited in those roles. We are better placed in those roles. We tend to have better outcomes, as Dr. Anaba has also pointed out. So as far as the Ghana Anaesthetists Society is concerned, we are working in hand with the ministry and the Medical and Dental Council. We are not downplaying anyone's role. We are not trying to assume full responsibility. We recognize their impact, we recognize their contribution, especially in the rural areas where our numbers are fewer. But we just want the recognition for our own members that there's the need for the supervisory role, and our relationship should continue to be respectful towards each other and complementary. And then in that case, the greatest benefit comes to the patient population. Thank you.
Thank you very much. Prof, you wanted to say something to this?
My line went off. Just to inform all the members of panel and those who are listening in, that last month, the Medical and Dental Council has actually launched the scope of practice for all physician assistant, medical, dental, and surgical registered nurse anesthetists. So that document is now legal. It's legal document for a scope of practice. So now, any regional director or district director of health can use that scope to also as a guide to streamline activities, because it's clearly spelled what they are supposed to do. In fact, in our document, it's more what they're supposed to do and the limitation, when they should ask for help, when they should refer, how to refer, documentation of care. It's all detailed in that document. So I don't know whether the document is online. They haven't printed a lot, but they gave us few copies when it was launched. So, and let me also say at this stage that it's not only the physician assistant grade. Eventually, every category of person working in the health sector will also have their scope of practice. So we should all be prepared for that.
Excellent, excellent. Thank you, Prof, very much. I'll just take a break from this very touchy issue and ask more benign questions. Prof, how is the work-life balance as an anesthetist?
The work-life?
Yes.
Oh, it can be challenging. It can be demanding on you. But you really have to plan everything. Things should not be allowed to happen without plan. So you plan your work, you plan your teaching, you plan your research, your married life, your family, your children. That's one advice I'll give to all the young people. They should not allow things just to happen. In the end, every bit of your life will suffer. One thing which I do is that I like reading. I'm always reading. I read a lot. I go to the net almost every day looking for information. I'm still doing it. I love teaching. But then in the midst of all this, I ensure that I also rest. As for rest, I do. So sometimes I say to myself today, nothing, I'm just resting. Because if you don't do that, you find that your body will just give way. So everything must be planned and everything must be held in proper balances. Where one is suffering, one part of your body is suffering, please let go for a time and try and see how you can manage the whole system. But for people like the residents, you need to do a lot of work to pass your exams. I tell people the course is 3 years, don't make it 6 years. You need to work hard. There's no turning back. We've had a few people who have come to the Department of Anesthesia in Kolibu. They've done a diploma. They're still not settled in their mind, and they have left. If you decide to come to anesthesia and you want to stay, then my advice is that you must prepare to do all the good learning and pass your exams within the stipulated time. Don't add any additional years to your course.
Thank you very much, Prof. I was going to ask everyone to just give us a single piece of advice you'd give to a junior doctor or a medical student who is considering anesthesia as a specialty. I wanted to save that for the last, but since Prof has already started this, I'll just go around and ask everyone one advice you'd give a medical student or a junior doctor. Dr. Fari.
I would say first and foremost, throughout your medical school days, keep an open, broad mind, but really consider anesthesia because of the factors or the reasons I gave earlier. You tend to get to apply virtually everything that you learned in the course of medical school. You get the patient contact, you get all ages of patients, both sexes of patients. It is a growing field. A lot of technological advances are taking place with regards to anesthesia. So you are not going to grow cold in that sense. As Prof has said, with regular reading, you are always on top of your game. Once you are considering critical care services, intensive care, once you are considering pain medicine, these are other branches of medicine that are not the entire domain of anesthesia. But with a background in anesthesia, you are very well placed. As far as resuscitation and emergency medicine is concerned, you are very well placed. So I would say it's a growing field. Yes, our numbers are few now. That's all the more reason why you can be with a growing field. There's a lot of room for expansion. The recognition is coming. The work is there, and the work is enjoyable. You see results there and then on the table, there and then in the recovery room. There are some pitfalls. It's not every story that may be a success, but there's a lot of learning, and there's the fact that you realize that you have contributed a great deal. So do consider it. Right, an important aspect I would point out is that make sure that the interest is there. Once the interest is there, you won't see it as a mundane, routine thing, sleep, wake up, sleep, wake up. There's much more to it than that. Every individual, every patient, every case differs from the other. Thank you.
All right. Thank you very much. As we draw to the close of our discussion, if you have any questions, you can just put it in the group chat, or you can just message me directly. I would ask our panelists. To Dr. Akwanyako, please, one piece of advice you would give to your younger self.
All right. It's Akwanyako. Akwa. Okay, so I would like to say anesthesia is a wonderful specialization. I've not regretted choosing it at all. You get the humdrum of medicine in critical care. You get the fast-paced nature of emergency and surgery. It's really, really nice. But then I would also like to say you can't give what you don't have. So even if you're going to start residency, you should also have time to relax and take time for yourself. And if you want to do anesthesia, you should be someone who can function very well in situations that everybody is running around. As an anesthesiologist, you should be able to keep calm, because if you're not calm, you are the head of the table. You kind of like exude vibes to the rest of the room. So if you as an anesthesiologist, you are panicking, then everybody else would panic. But you should be able to keep calm when everything seems to go haywire and do the best that you can. It's a really, really lovely specialty. I'm enjoying myself, and anesthesiologists are family. Like, we tend to play together, to work together, to learn together, and you should do it if you are thinking about it.
Very, very good input. Actually, I'll attest to that. Actually, I'm also a surgical trainee, But then we look at our anesthesia colleagues and you realize that these guys are really being pumped a lot. It's like they get carried everywhere, teach them this, teach them that. I mean, it's a little bit different for the surgeons, but then I really admire that aspect of, holding the juniors as a family and then teaching them. All right, Dr. Naba, finally.
Thank you very much. I think you said a lot about the specialty. What I would in the Bible, it is the first specialty God created on earth. He used it to sleep. If also believe in the Bible, it is a specialty that puts you on top. You are able to mingle with any other specialty in the world. It uses a lot of technology, and I know every doctor now likes technology, so you can deploy technology. What it is that you must be careful is that it's very addictive. Anesthetists would like to see their patients from beginning to end, and even if there's a problem, they go home and come back to make sure they are fine. Make sure, like Prof said, have a rest to recover your body. Anesthesia is very addictive. It will keep you working and working and working. Now you see you break down. But that should not scare you from doing anesthesia. All those who want to do anesthesia, you are welcome. Join the family of the eminent group, and you'll be a happy person.
Thank you. Thank you very much, Dr. Naba. Thank you to all our panelists. We are really, really grateful that you took time off your busy schedule to actually join us this evening. We're just 2 minutes above our closing time. If anyone has any questions, all right, I think we have one here. I think this may already have been touched, but I'll still ask the panel anyways. The question is, what else does anesthesia entail aside putting patients to sleep and critical care? And of course, Candy Crush, and then documenting what the true estimated blood loss is. Apart from those, please, what are the other things anesthesia entails? To anyone in the panel, please. I can see Dr. Afari has unmuted, so.
Yes, I've unmuted. I think all of us can chip in a bit because we'll all have a part to play. We'll all have a voice in this. Anesthesia is not just putting the patient to sleep and waking the patient up. Anesthesia is the total care of the patient before you put him to sleep, while he's asleep, waking him up safely, taking care of him afterwards. We are constantly considering the physiology. We're constantly reviewing the pharmacology we're dealing with. And when you say putting to sleep and waking up, it's not just limited to general anesthesia. Right now, we actually have some of our fellows and some of our members doing their fellowship in regional anesthesia. So regional anesthesia is not just the spinals and the epidurals, but they're doing concentrated and multiple nerve blocks. That is interesting, that is fascinating. Apart from the intensive care aspects, we do a lot of research. There are a lot of avenues for research if you are considering going into academics or publications. Anesthesia will give you that data. Also, pain medicine is an important aspect now. I'm sure Professor Mponsa will talk more about pain. That is one of her pet projects. But then pain medicine is important. Pain is a fundamental, abolishing or eliminating pain. It's a fundamental human right, if I may put it that way. And anesthesia puts you in the stead to continue with pain medication, not just with the original aspects of pain medication, but anything else, even if it's going to be systemic or other modalities, to make sure that our fellow colleagues, our patients, all those in our care have a good experience. I'm sure my other colleague panelists will have something to add, but I'll quickly, having the floor, like to thank the organizers. I think this is a very well thought out program. This is a good way of mentoring our junior colleagues, medical students coming out, giving them, not just attracting them into anesthesia, but giving them the broad basis so that they know whatever they are getting into and they enjoy it, because it's going to be more or less lifelong. So thank you very much to the organizers. And I hope my other panelists can also chip in a bit more as to what makes anesthesia more than Candy Crush. For the records, I don't even know how to play Candy Crush, and I don't even have a single game on my phone. because there's always so much going on that I'm not going to be stuck behind the game. Thank you.
Yeah, can I just say that surgery has progressed because of anesthesia. Why am I saying that? How do we put a patient who's 110-year-old to sleep? Which means the anesthesia is not just putting people to sleep. That's what Jonas said. Anesthesia is given to babies who are in the womb, brought out, operated upon, and sent back to the womb. So the sophistication of anesthesia alone is enough. Now, Dr. Fred touched on pain. Pain is my baby, I should say. If you take pain medicine alone, the research is unlimited. We are beginning, after my inaugural lecture last March, we are beginning to see what we can do to really bring pain management to the fore in all healthcare. Not only in surgical patients, we have trauma, pediatrics, everywhere there's pain. The other thing which we eventually come to UK now, the anesthetists are calling themselves perioperative physicians. There's not enough time to talk about that. So we have now that to just say that we are moving on. We are not staying in one place as anesthetists, as a profession, as a specialist. We are seizing every opportunity to move on in all directions. And that's why UK, they are called the perioperative physicians. I'll stop here because there's no time.
Thank you very much, Prof. Is there any other one thing, Dr. Anaba or Dr. I
think one other thing I'll add is that now we have what we call interventional radiology, and this requires the intervention of anesthesiologists in even the imaging. Quite excellent anesthesia for those interventions to take place. Besides that, we have what we call transplants. A transplant without a good anesthesiologist, you will do finish and the patient will not wake up. So you need anesthesiologists to support you in doing all these transplants. Anesthesiologists also help in even manufacturing of medical devices. Anesthesiologists are key people, consultants in doing such things. So it's not only sleeping people. As I'm speaking to you right now, I'm in my scrap. I'm giving labor anesthesia to a woman who is currently smiling and is in labor. That is so rejoicing. So anesthesia has a lot to do. One specialty that has so many pathways for you to take, and you will never get tired. Join anesthesia.
Thank you very much, Dr. Akua Nyaku.
All right. I don't know why a lot of people tend to think anesthesia actually is just we put the patient to sleep and we sit down. It's so much more. Like
that was pun.
I know. As an anesthesiologist, your ears have to be sharp to pick up the change in tone of a oxygen saturation monitor. To pick up, it's like you are always alert. I learned that at the very beginning of house job in anesthesia, that you tend to have to look at the overall picture. You can't be skewed to the status localis. You are looking at the patient's heart rate. You are looking at the patient's respiratory rate. You are looking at the patient's BP. Is this matching? Is the patient still alive? Is the carbon dioxide normal? You are concerned with the entire safety of the patient. And without an anesthesiologist, the surgeon might as well be doing a postmortem. So it's very, it's very, very important. And as my bosses have said, there's so much with the critical care aspect, which I think it's now a lot of people are knowing more about. But then the pain medicine, regional anesthesia, interventional radiology, sedations, even sedations for some procedures, CT scans, radiology, chemotherapy, radiotherapy, all those things are handled by anesthesiologists. So it's really, really very, very broad specialty. And someone was saying, when I talk about being using my hands, you see, when we do laryngoscopy, we do central lines, we do even getting your needle in position for your regional anesthesia, your ultrasound, being able to hold your ultrasound and still put in your needle and everything. You have to be you have to have dexterity. Yes, that's the word, dexterity, to be able to do all that. So that's what I mean by being able to work with your hands.
Thank you very much, Dr. Akwa Nyako. I'm just going to ask one last question. So this question is from one of the audience to Prof. Is there an opportunity for joining conferences locally or internationally organized by the Association of Physician and Anesthetists? Do we have any local conference that we organize as anesthetists in Ghana?
In fact, that question, if Jonas is still, he is the secretary of the, anyway, we have Ghana Anaesthetiologists Society, and every year we have conferences, except for the last 3 years when the COVID really stopped us from doing it. In fact, I've even spoken to the president just a few days ago to remind him we are getting to October. Normally we do it in October because 16th October is our day. That's we say as children, is our day. We use 16th October as the day anesthesia was officially launched in the US. So we have meetings every year. Hopefully we have one this year. Everybody is entitled to come. You don't have to be a physician. We allow non-physicians even to attend, non-anesthetists to attend. So look out for the posters and the announcement. It will surely come, as the president informed me a few days ago.
Okay, thank you very much, Prof. Dr. Afari, do you have a date?
Abroad is more expensive these days. It's more expensive these days to travel, and sponsorship is not very easy to come by.
Yes. Yes. So as far as dates are concerned, thank you, Professor Aponsa. Yes, actually pointed out, usually because of busy nature, we try and factor our activities around World Anesthesia Day, that is the 16th of October. And then we have refresher courses that's more in line with the West African College of Surgeons. And so we tend to have our refresher courses in February. Otherwise, and then especially at these 2 times, we factor in our colleagues in other fields. So our World Anesthesia Day related activities, we try and have something that is of interest to the anesthesiologists. We have something that is of interest to general, like other medical practitioners, and then we incorporate something that would be of interest to the general public. I think last 2 years, we spoke extensively about analgesia and then obstetric labor analgesia. Last year, with the COVID-related episodes, most of our emphasis was on critical care, and then a lot of people were hearing for the first time about intensive care units. So that's what the domain was. We are still waiting for directions from the World Federation of Society of Anesthesias. We try and streamline our theme to be part of the international theme for the year. But definitely, now once I have your audience, once the fine details come out, I'll let the organizers know, and then through this medium, they can make sure that you're all informed and you're all invited and encouraged to participate. Thank you.
Thank you very much, all of you, for coming. Thank you to our panelists as well. I'll just invite our secretary to just give us a short announcement. We aim to be done with the meeting in a couple of minutes. Dr. Sosai.
Yeah, thank you very much, Peggy. I thank you all, our dear panelists, for the time and dedication present for this meeting. We at InciSioN Ghana, we can't really find the words to say thank you. We are really, really grateful for that. And for our participants, we have our ongoing webinars. The next one is coming up next week. We'll be publishing the dates and the time to you very soon. So thank you for coming, and we are very much grateful. Have a lovely day.
Yes, I think it's on 26th. 26th
Friday.
at Friday at 6 p.m. And I think they will be discussing data analysis as well. This will be our 6th webinar on the research process. And for all those who are participants in the mentor program, please carry on the good work with your research projects and those in the systematic review groups as well. Just keep on with the hard work. Thank you very much for coming.
Thank you for having us.
Thank you, Prof.
Thank you for having us.
Thank you.